ठीक है सर, स्टार्ट कर इसका वॉल्यूम दे दो, इससे
म्यूट कर। चलें। अच्छा, मैं first of all, Assalamu alaikum everyone. I'm sure that now you would be able to hear my and our voice from here. Today we are going to discuss a case of pregnancy with fibroid, and Dr. Fiza, second year MCPS resident of Niglatin Hospital, will be presenting the case. She's got 9 slides, and after that I will take about half an hour in talking about the implication of ARIA or fibroids, the effect of pregnancy on fibroids and vice versa, fibroids on pregnancy. So let's start with Dr. Fiza's presentation.
20-year-old female, graviда 2, para 1, abortion 0, presented at 12 weeks of gestation. Previously, she had an uneventful emergency. 30-year-old female, gravida 2, para 1, abortion 0, presented at 12 weeks of gestation. Previously, she had uneventful emergency cesarean section due to decreased fetal movements and non-reactive CPT. Her ultrasound shows gestational age of 12 weeks and 5 days with a large intramural fibroid of 86 into 132 into 150 millimeter in the anterior wall and left lateral wall of the uterus. Next, please. Next. What are the maternal and fetal complications associated with pregnancy with fibroids? What will be your plan of management? How will you counsel her regarding the risks associated at the time of cesarean section?
Now here I'll take a pause, and I want all the participants to consider these 3 aspects. Obviously there would be more which may be labeled as supplementary questions arising from those, like they have supplementary questions in the assemblies or parliament. Similarly here there would be supplementary questions arising of these maternal and fetal complications associated in pregnancy, which is complicated by fibroids. And similarly, questions arising from the plan of management. And then, of course, counseling regarding risks associated. Now, this question actually takes it for granted that one is going to do cesarean section. As a matter of fact, how will you counsel her regarding risks associated with the pregnancy throughout, during the pregnancy, as well as at the time of delivery, oblique cesarean section? So these are the various questions which you must consider, note down, and have answers ready, all your questions.
Maternal and fetal complications. First of all, sir, we discuss the maternal complications. Maternal pain is the most common complication and is more evident if the fibroid is and is during the second and third phase. Caused by the red degeneration of the fibroids or torsion of a penetrated fibroid, where the prostaglandins are released as a result of the cell damage. Fibroids can also cause pressure symptoms. Other obstetric complications arising during pregnancy are preterm labor, placental abruption, increased incidence of cesarean section, retained placentas, double risk of placenta previa, increased potential to bleed significantly in the pregnancy, and increased incidence of bleeding after delivery. Fetal outcomes. Increased incidence of miscarriages in the first trimester, which is about 40%. Rarely, the fibroids are associated with fetal anomalies, possibly caused by the compression effects from the large fibroids. These include limb reduction effects, leukocephaly, and torticollis. Plan of management. Sir, first of all, we'll discuss the antenatal care. A consultant-led care is advised for the women having fibroids greater than 3 cm in diameter, or those which are located adjacent to the placental site or cervix. They should be considered for a consultant-led care. Treatment and prevention of anemia prior to delivery is essential to decrease the complications from major hemorrhage. Serial bone scans are advised in the patients with large fibroids as dysphasial fundal height measurements become inaccurate. It also helps in the identification of rapidly enlarging fibroids. and those which are having suspicion of malignancy. Fibroid pain in the antenatal period may need hospital admission and the use of paracetamol and opiate-based analgesia. The mode of delivery in this patient should be by cesarean section. Counseling regarding the risks of cesarean section. So I would counsel my patient as the size of her fibroid is large and she is having a previous one cesarean section. So there are chances of excessive bleeding, risk of hysterectomy, admission to the intensive care unit, and modified sleep institutions.
What do you mean by modified Cesarean?
Sir, usually we give preference to incision section, but sir, we may counsel her that we can through your students to classical cesarean incision and sir modify.
Classical Cesarean का क्या मतलब? Skin and CN नहीं होता classical.
Midline uterine incisions दे सकते हैं सर. Important tissue.
Midline uterine, midline abdominal.
जी जी सर, midline abdominal incision के लिए और सर इसके अलावा सर उसमें सर हम
चलिए ठीक है ये हो गया. I think I'll take cue from Dr. Fizza's slides. ये जरा third slide से लगा दें फिर से fourth से. आपके पास है ये दे देंगे. आपके पास है? हाँ. All right, maternal and fetal complication. Maternal pain is the most common complication. Well, you can start with discomfort. Obviously, it depends upon the size of the fibroid. More evident if the fibroid is more than 5 centimeters. Yes, but it's not really as common as one would think. If the large fibroid is there, red degeneration or those changes which take place in pregnancy, they can cause pain and similarly torsion of a pediculate fibroid. That is there. I'm sure all of you must have seen some cases of or managed cases of fibroids during pregnancy. First thing is, this is not something to be afraid of. Of course, this is a complicated pregnancy which needs extra care, which needs input of senior faculty and during the management of pregnancy, as well as for the management of plan of delivery, whether normal or cesarean section. So maternal complications, well, this is it, but there would be some other complications which will be there, which will be part of this. Now, these are pregnancy complications. Actually, they relate to mother as well as the fetus, preterm labor. And before that, I'll also put an increased incidence of miscarriage. I think that you have placed it somewhere. Fetal complication. And so, effect of fibroid on pregnancy is if you start right from the beginning, even preconception period, fibroids are an important cause of infertility. So fibroids can cause infertility. If pregnancy takes place, then ये voice नहीं है, वो कह रहे हैं कि voice नहीं आ रही.
Their voice बिल्कुल ठीक
ठीक है.
उन्होंने nothing proper नहीं किया.
Dr. Hani and Dr. Farrukh, our IT team tells us that there may be some problem with your login. Kindly log in or re-log in after logging out. All right, the voice is clear. So there is increased chance of miscarriage. You quoted about 14%. You see, these days spontaneous miscarriage rate is being quoted from 20 to 25%. It's pretty high. Previously, we used to quote spontaneous miscarriage rate as 15% as such, not associated with fibroids, but as such. Now, this means that there will be increased chance of miscarriage over the spontaneous rate of miscarriage, because those spontaneous miscarriages are mostly because of chromosomal abnormalities, like 60 to 70% of them. And add on to that the complication of the fibroids, so it can cause. And it is not difficult to understand why fibroids would cause miscarriage if you visualize the uterus and the change in the uterine configuration, which the fibroids, depending on their location, can cause that. We'll come to that later on. Placental abruption, increased incidence of cesarean section, of course, and retained placenta, double risk of placenta, why we call double risk of placenta. Well, that will come to when we look at the configuration of uterus. Increased potential to bleed significantly in pregnancy, of course, and increased incidence of bleeding after delivery. Fetal outcomes, miscarriage, rarely fibroids are associated with fetal anomalies, possibly by compression. All right, we'll go along with that. Consultant care led treatment plan, serial growth scans, fibroid pain and antenatal period paracetamol, and in this, during the pregnancy, I think right from the beginning, general approach of the obstetrical team towards the patient management should be that of reassurance and explanation, telling that the fibroid is there. It can cause discomfort and pain, which is because of the changes which take place in fibroid, number one. Number two, because of the increased mass of the uterus. In twin pregnancy, the discomfort is more than a singleton pregnancy. So fibroid by its volume can have mechanical effects and cause discomfort. And if the patient is prepped up during the early period of pregnancy and is encouraged to be adopt a stronger kind of attitude and a positive attitude towards her pregnancy, at the same time reassuring her that the pregnancy and the baby is going to be all right, it's not going to be adversely affected, and we'll do all that is possible to keep your pregnancy safe, your baby all right, and you also safe. That is quite a lot of help to the patient. So at every visit, you reassure the patient, be a little conversational with her, and do make some comments, positive comments about the fibroids, or not to be afraid of that. That's important. And that is, as a matter of fact, more important than giving analgesics. Because in pregnancy, the choice of analgesics that we can give is very restricted. Paracetamol, NSAIDs can't be given because of the effect on the structural effect on cardiovascular system. Paracetamol, yes, but even now there are reports about paracetamol, there being some cognitive compromises in those babies or those children who whose mother took paracetamol while they were in the uterus. Opioid-based analgesia, it is not available so commonly in Pakistan, and America is having a lot of problem with opiate dependence, and therefore I wouldn't really be inclined to provide opiate until and unless it is absolutely essential, and sometimes it does, but those cases are very few and rare. And mode of delivery in this particular patient, since she has had previously a cesarean section, and the site of the fibroid is such, it is anterior lateral wall, and it is likely to be an obstructive element for normal delivery, and particularly because of the previous cesarean section, I would say yes, she should have a cesarean section. So the patient is going to be counseled about size of the fibroid is large, there are chances of excessive bleeding, risk of. Now, these are all bad news. They are all negative. Intensive care unit, modified skin, scene, etc., etc. But again, these are the realities. This is something which needs to be discussed with the patient. But we need to again adopt an attitude where we do inform the patient of the possibilities, but at the same time reassuring that there are ways and means to address these problems, to take care of them, and ensuring as far as possible the well-being of the baby as well as the patient. For example, when you say that there are chances of excessive bleeding, you can also incentivize her to take iron regularly, and to check her hemoglobin from time to time more frequently. And if there is need, you can give iron by injections. We need to unfortunately explain to the patient and the family that the arrangement for blood, cross-matched blood has to be made by the family, as blood transfusion services are not so well developed in our system. And that is the explanation for telling them about excessive bleeding, which may be attended with delivery or even sometimes before that. Risk of hysterectomy is very small, that you can say that in any pregnancy, if there is excessive bleeding, that's always a background risk which one may have to resort to. And admission to intensive care as a result of all these complications, and that's again to not to scare the patient, but to tell her that we have the facility, and we, if needed, we will care for you, take care of you in the intensive care, but that is not so common. Modified skin and CN, not necessarily if you have to. This is actually an extra thing, because these days usually we employ fan and steel or transverse lower abdominal CN. When I was training at that time, we were making midline incisions at that time, and as a result, we had a lot of patients who came back with the incisional hernias, and our general surgeon colleagues at that time, they used to chide us about the choice of our incisions. These days, vertical incision, midline incision of the abdomen is indicated only in few instances if one expects that there are issues in the lower part of the uterus, and you have to bring out the baby from the upper part of the uterus, like in placenta accreta, if you want to deliver the baby from the fundal area, for example. So it will not be possible through transverse incision, or transverse incision takes a little longer in cases of moribund patients with excessive antepartum hemorrhage who want to empty the uterus and deliver the baby. Midline incision is comparatively quicker incision and shortens the operative time. So I can think of only these two causes. Right, this is all your slides, and now I will come to my slide and I'll try to go through them. ये मैं screen share करने लगा हूँ. मैं अपनी mic on कर दूँ या उस पे ठीक है?
Mic आप mute रहने दें. Mute रहने दें आप.
मैं mute ही रखूँ?
जी.
Okay. चलिए क्वेश्चन पे आ जाएंगे. Modified skin and CN we will open by previous. Yes, this of course we will do that. Okay, the pregnancy with fibroid, and this is the case. Okay, this is the case. We talked about it. Now I'm going to talk about the fibroids as such. First of all, the classification of fibroids. We'll go to that. This classification was proposed or was devised by FIGO's special committee and was presented in the FIGO's International Conference in 2009, and it came out in the form of a paper published in 2011 in International Journal of Gynecology and Obstetrics. The palm coin, you all know, and for illustrative purposes, a coin is shown here, although the spellings here are different because an E is added. Coin, this coin doesn't have an E, but this is an E. And this is actually for abnormal uterine bleeding, of which leiomyomas are an important cause, being submucosal and others. And then we look at the fibroids. It is important to realize that their situation or their placement vis-a-vis the uterus the cavity. If there is it's pedunculated submucosal fibroid, that is 0. And then you go on to these 9 total classifications starting from 0 to 7. So these are the classifications. You should know a little bit about that, how much they are there, etc., etc. And this is the classification given in detail. Now, fibroids in pregnancy, as you know, fibroid is the commonest tumor in the female. As a matter of fact, fibroid is the commonest tumor in human race, although it occurs only in 50% of the population, that is only in women, but it still is the commonest tumor because it is present in almost 70% of women over the age of 40. Small, large, one, multiple, and although here it says 20 to 40%, but this is almost in comparatively younger women. In older women, the incidence is much higher. And the estimated incidence in pregnancy is 0.1 to 3.9%. So there is such great variation depending upon the preponderance and prevalence of fibroids in a given population. Since fibroids are said to be more common in, say, blacks and in some other races as well, gradually it is becoming politically incorrect to now bring in race when we are talking about certain diseases. But still, the fact of the matter is that it is commoner in darker complexion people or women. And again, you know, they have started calling not women but people, although they occur in women so far as I am concerned. So estimated incidence varies greatly between 0.1 to almost 4%. And in pregnancy, mostly they remain asymptomatic, and complications in fibroids occur in 10 to 30% cases. Ari, आवाज ठीक आ रही है? On your mic there.
Yes, sir. Voice is clear, mashallah.
आवाज आ रही है? मेरा माइक बिल्कुल
जी सर, बिल्कुल ठीक है. अब वॉइस ठीक है.
मेरा ख्याल है मैंने ऑन नहीं किया हुआ. कर लूं?
नहीं सर, एक्टिव है.
अच्छा ठीक है. ठीक, okay. So these are the essential initial some statistics about fibroids and their chance in pregnancy. Now here, this is these are the pictures which I have taken from internet. This is the pregnancy sac, early pregnancy, and here you can see a fibroid. This is a large cervical fibroid. This is an MRI. Obviously, you don't do a CT in pregnancy. This is, and here they have shown the fetus. I wouldn't really go to the extent of an MRI. Our ultrasound is generally, we have good faith in that. Now, this is a picture which I took only day before yesterday. These days, I have 3 patients who have a pregnancy with fibroid. And here you see that there is this large fibroid. And this is about 12 to 14 weeks pregnancy. And this is the fibroid. And here you see part of the fetus. And here again, this is the zoomed out view. This is the fibroid, and here is the fetus. And this is a picture which I took yesterday. Here you can see part of the placenta actually here, and this is a large fibroid over here. This is again, this is part of the fetus fetal head, and this is on this side, there is the fibroid. Now, what happens if the fibroid? Well, in this presentation, I'm going to introduce you to another aspect of studying or preparing a topic. You see, for this one, I looked up at the net and searched for few of these associated conditions like fibroids and pregnancy, etc. And I came out with some of these papers. And I'm going to present the, you see, summary of these papers. Outcome of pregnancies in women with uterine lymphomas identified by sonography in the first trimester. So, but these are applicable to overall consideration of fibroids in pregnancy. So high risk of spontaneous pregnancy loss, as I said earlier, that there is, because of fibroids, there is an enhanced chance of abortion. Loss rate higher in patients with obviously, because in those cases, the distortion of the uterus is, if you would go back to that picture when we were looking at the fibroids classification, you can visualize that if there are multiple fibroids, there will be greater distortion of the uterine cavity, and that will interfere or impede proper placentation. So if because of that, if there is improper attachment of the placenta, then chances of miscarriage would be high. Cesarean section rate is higher in patients with fibroids than in patients with a normal uterus. These are obvious conclusions, but you need to have some backing of that. And if you would want to, in such cases, you can give reference of the study or that journal. So you write down these 3 points, and in front of that, you can write this one. So you would know that there was a study in Journal of Clinical Ultrasound in 2001 January, and this was the title of the paper. Now then, the effect of uterine fibroids on fecundity. अब fecundity जो है इसके बारे में क्या है? What do you know about fecundity? Fecundity is the potential to become pregnant. And once, as I said, that it causes infertility, so that is the effect on fecundity. And once the pregnancy is there, then the effects on pregnancy or pregnancy outcome. It is not really possible to gather information about the effects and overall type things, because mostly it will depend upon individual experiences. Since the fibroids with pregnancy are not so common, and therefore that's why there is lack of adequate large clinical trials, as prevalence of fibroids in pregnancy is underestimated, complications are overestimated. As I said, that at the present time I have 3 patients with fibroids, but they go unnoticed. I have had patients previously also, but since we do not maintain record, we do not publish those. That's why our observations, they go unnoticed. So my suggestion to all of the younger generation is that if you can keep a record of your patients, these days, these mobile phones, they afford us the opportunity of taking photographs whenever we want. So photographs of ultrasounds, I just took that in an ordinary ultrasound machine yesterday and day before, as I showed you those pictures. So you can also take those photographs. Internet has made it so easy for us to get proper references. So you just have that reference like this one. Previous slide, you have, or in this slide, you have this paper, Obstetric Complications of Fibroids. This is Obstetric Gynecology Clinics of North America and March 2006 issue. And this is the summary of the its assessment. And then most pregnancies are unaffected by presence of fibroids and they go unnoticed. What happens is that the fibroids do increase in size with pregnancy, but gradually they also become comparatively softer. And as pregnancy grows, the fibroids, they become kind of flattened. And initially, if you were able to identify a few fibroids, see on ultrasound, later on it becomes almost sometimes impossible or difficult to visualize those because they are flattened and they are gone out of the view. And that's not uncommon. So therefore, those fibroids will not really be affecting the pregnancy in any adverse manner. But large submucosal retroplacental fibroids, of course, if the fibroid is, then the risk of complications will be higher, starting with pain, vaginal bleeding, abnormal lie of the baby would be because of, again, changes in configuration. As the uterus grows in the 3rd trimester, particularly if you look at the uterine cavity, it is an oblong cavity. and the fetus assumes its position according to that. In the lower part of the uterus, that's comparatively narrower. The upper part, frontal part, is broader, and the fetus normally fits itself according to the space available, which means that the buttocks, which form a larger mass, they occupy the frontal area, and compact fetal head that comes down to occupy the lower pole of the uterus. Now imagine if there were a placenta previa lying down in the lower part of the uterus, that would change the configuration of the uterine cavity from an oblong one to a rounded one. And therefore there may be an oblique line or a transverse line or a breech presentation. So any factor, it could be a fibroid, it can be a placenta, it could be an ovarian tumor which is pushing the uterus up, or sometimes even previously it used to be said if there is a contracted pelvis, it would push the uterus up and make it more kind of rounded. It wouldn't allow the lower pole of the uterus to come into the pelvis and would also be responsible for so if the uterine cavity is rounded, there can be abnormal lying. So placental abruption, again because of less than optimal attachment of the placenta. Intrauterine growth restriction, if the blood supply to the placenta is not enough. Preterm labor, and birth because of various factors. Number one, the compression of the uterus and the disturbance with the normal configuration of the uterus, so-called bipolarity of the uterus, etc. They can affect that. So these are some of the complications which can be there. Then myoma and myomectomy. You see, a few years ago, I attended a conference in India where Indians showed quite a few of their videos where they were doing myomectomies during pregnancy. When I was training at that time, the wise comment was that myomectomy during pregnancy or at the time of cesarean section is a surgical crime, until and unless the fibroid was lying right in the line of incision in the lower part of the uterus, and where you have to enucleate it and then get to the fetus. Otherwise, it used to be called surgical crime. Over the last 3 decades, the viewpoint is now changing, and now there are, you would find quite a few papers. This one is the Journal of Obstetrics and Gynecology of wherever. This is 2017 edition, and that shows you about, and there would be a couple of more references which would show that myomectomy during pregnancy is and at the time of cesarean section is something that can be considered. Now, this is because of the changing demographics. For example, delayed childbearing leading to an increase. Now, women, they many of them, they are busy with their education or their professions, and they delay childbearing. And it is not uncommon to come across primigravidas in their 4th decade of life, in their 30s. So at that time, because of delaying pregnancy, the chances with passing years, the chances of developing fibroids become more and more. So either there will be fibroids or there will be scars in the uterus of the previous myomectomy. So that is the kind of, that's why the incidence of fibroids during pregnancy would be getting more. 10 to 30 pregnant women, percent of women with myomas develop complications during gestation. Submucosal, retroplacental, large, and multiple have greater risk of complications. Cervical myomas rare, need careful management, and location and size of the fibroid should be assessed from the first trimester. This is important because it lets you know where you stand, and then it helps in planning the management and of the pregnancy, as well as planning the mode of delivery or the possible recognition of complications which may be there. Now, fibroids are not a contraindication to labor unless they obstruct the birth canal. So presence of a fibroid, with that, you can let the woman go into labor, or you can even induce. Myomectomy during pregnancy in selected cases is feasible and safe. Underline this, selected cases. So you can't really say that myomectomy in all cases, it has to be selected cases. And if you are doing it or going to do it for the first time, then you ought to be doing it in collaboration with someone who is experienced in it. Because even at this stage of my career, I would be very hesitant in performing a myomectomy as such. And the pregnant or recently pregnant uterus, or the one which has only been just emptied of the fetus, is very vascular organ, and it sometimes can be difficult to manage that bleeding which can ensue from that incision in the uterine wall. Uterine rupture after myomectomy generally occurs in the 3rd trimester or during labor and some associate. This is of those scars which are of previous myomectomy. Although last year I had a patient, we did her hysterectomy for her only a few months ago. I did her, she had 3 cesarean sections, then she presented with fibroids. I did her myomectomy in January 2020 and asked her not to get pregnant for 6 months. Now this is arbitrary. I would say at least 6 months should pass for after myomectomy before the plans a pregnancy, because that would be the time that is required for proper healing to take place. She had myomectomy in January, and her last menstrual period when she presented with pregnancy was in March. Just 2 months after that, she became pregnant. She had her 4th cesarean section. The pregnancy went off quite all right. And of course, 3 cesarean sections, 1 myomectomy, and then she had 4th cesarean section. And a year after that, then she came in again with fibroids, and she had hysterectomy. So anyway, the rupture of previously carried out myomectomy scar it can take place in 3rd trimester. So that is something these days with the ultrasound, I believe that one can look at that area or any area of weakness, which will not be easier to find out. No, it's a very large uterus, and when we ask our ultrasonologists to assess the lower uterine segment, that's quite easy, and that's easy to identify because of the proximity of the bladder. That shows that here is the lower uterine segment, and you can measure its thickness. But try to imagine the posterior wall of the uterus in the same area. That would be a little difficult. And scanning whole of the uterine wall to identify where the scar is and what its thickness is, that is going to be quite a difficult task. After myomectomy, how much time to wait for conception? As I said, I would advise 6 months. There is no consensus on the optimal interval between myomectomy and conception. So, but I said I gave you my reason for 6 months. Pregnancy in patients with fibroid or previous myomectomy should be considered as high risk. Again, that is not to be overemphasized to the patient. And the available literature is inconsistent on evidence-based management. Again, because of the paucity of data, you see, and that's why there is no evidence-based management as such, and it all depends on individual experiences. Now, if you are going to make this kind of comment in the examination, it is then would be better to have a reference ready. For example, you can say that this is the article and this is the reference of that. The change of pattern. All right. Now, this is myomectomy and pregnancy. When do you do preconception myomectomy? That is to improve reproductive outcome, chances of pregnancy, reducing chances of pregnancy loss, and of course, removing a large submucosal fibroid, which may have been causing infertility. Or in those cases, if the fibroid is there and the patient has had recurrent pregnancy losses and there is no other cause for that. Antepartum means that myomectomy during pregnancy. During pregnancy, well, you have for subserosal or pedunculated fibroids, which may be like Fiza said, which are giving rise to problem, and there is red degeneration, intractable pain, or there is like intractable fibroid pain that are unresponsive to medical therapy, and that too in the first or second trimester of pregnancy. During cesarean section, significant morbidity and hemorrhage is likely at the time of myomectomy and should be pursued with caution and only in select patients. Sometimes you may be faced with the situation where this is the only thing that you have to do by removing the fibroid. But I personally would steer clear of a fibroid as far as possible and plan my incision according to that. We had a patient who had a large fibroid. I don't know, probably Sarda, you sister me that. She was the sister of a doctor from Surat, and she had a large fibroid in the lower part. And we gave a midline incision, and I approached above that, and my incision was almost at the level where the right round ligament was meeting the fundus of the uterus, and I gave incision in that area and removed the baby, delivered the baby rather, and staged it up. And we later on, after an interval of 6 months, carried out myomectomy of that because that was a large fibroid. So I would not venture in to remove the fibroid and proceed with that. I am rather afraid. I'm very conservative about that. Now, this again is a picture. This was a case report published in the paper. Here you see a large fibroid in early pregnancy. This is the uterus and this is the fibroid, because here we can see at the time of operation that the fibroid has been removed, and this is the pregnant uterus, which is about 10 to 12 weeks pregnancy, or maybe a little more than that. And this is the size of the fibroid. Now, this is something which could be done in the first and second trimester, as already said. Pros and cons and the outcomes of cesarean myomectomy. Now, this is when you are doing it, demonstrated advantage of cesarean myomectomy. Postponed myomectomy after cesarean section was recommended in some instances. So it is better, as I said, I was quoting my case, that I delivered the baby with a higher incision and did an interval myomectomy. Apart from recent reports on safety and feasibility of cesarean myomectomy, the current literature also describes serious complications of cesarean myomectomy, including even maternal death. So this is something to emphasize, that it is not to be taken rather easy. Although some studies strongly suggest the safety of cesarean myomectomy, data at the long-term outcome of cesarean myomectomy in women are lacking. So there is not enough of data. There would be individual experiences, and those would be, of course, they can be counted, but until and unless there is large amount of data, you cannot quote that. The risk-benefit ratio of cesarean myomectomy should be re-evaluated given the increasing patient age, incidence of myoma in pregnancy, and the wide use of ART. ART obviously is done in many of the instances, particularly in our part of the world, when all other options have been exhausted, and that also means that the patient's age would be advanced, fairly advanced by that time, and by that time the chances of having developed fibroids would be more, as that would be the possibility in the 4th decade of life. Myomectomy during a cesarean section is controversial, although the pros and cons, continuing with that, is that it provides the opportunity that you carry out 2 procedures in one operation, and you save the patient another anesthesia expense and hospitalization. Where cesarean myomectomy may be associated with increased morbidity, it is again repeating what has already been said. And myomas compromising fetal extraction and uterine incision and or suturing should be preferably enucleated during cesarean section. Sometimes it does happen that there is a fibroid which is kind of flattened. And what you can do when you give an incision, you can see part of the fibroid projecting in the, say, anterior wall of the uterus. So what you can do is that through that margin of that incision, you excise that, stitch it up, and then you close the uterine wound. Cesarean myomectomy is generally considered relatively safe in cases of obviously anterior wall myomas and those which are subserous and pedunculated, particularly if a myomectomy is feasible without additional hysterectomy, which means that without giving an additional incision in the uterus. And the conclusion of this paper was that with increasing reports in favor of cesarean myomectomy, the risk-benefit ratio should be still evaluated with randomized controlled trials in order to achieve more data on cesarean myomectomy. Rate of uterine leiomyoma grow. This is important, that how quickly they grow. It is interesting to see that the maximum growth of the fibroid takes place in the first and second trimesters, which is 54.5%, and less degree between the second and third trimester. It's less. So roughly saying that the first half of the pregnancy, the growth of the fibroid is maximum, and change and no significant growth of the leiomyoma between the second and third trimester. So which means that after say 25 to 25 weeks, there isn't much further growth in the size of the fibroid. And change in size during the whole of the pregnancy is significant, which is almost 95%. So almost 100% change in size, which is enhancement. And the conclusion of this paper was that uterine leiomyomas tend to grow substantially during the first trimester of pregnancy, and this trend is attenuated later with minimal growth towards the end of gestation. And this is probably the last slide. This is something which we already discussed. And the management summary is that first line of management is conservative with counseling for myomectomy after delivery. Intractable symptoms, this is antepartum or cesarean, not cesarean, myomectomy during pregnancy. So intractable symptoms, antepartum myomectomy or myomectomy at the time of cesarean section in carefully selected cases. ये है, अब सवाल आ रहे। Retroplacental fibroid is, you can say that the fibroid over which the placenta is attached.
Which cases we will consider that we can deliver the patient normally with a normal vaginal delivery, or we can select the patient for a cesarean section in which fibroids? Like
a fibroid which is in the lower pole of the uterus, which is obstructing the, which is mechanically obstructing the passage of the baby fetus from the uterus in the birth canal. That would be an advantage, right? Otherwise, or if because of the fibroid, the lie of the or presentation has been changed to abnormal, it's breech presentation or it is transverse line. So if it is not in direct line of the birth of the baby, then
and we will decide that according to the first trimester scan of the patient.
At the end of the pregnancy, depending upon where the fibroid is, what is the size of the fibroid, and how much affected it. Intramural fibroid, well, we haven't really talked about intramural fibroid in pregnancy. When I said that at the time of cesarean section, if you find that there is a fibroid in the anterior wall, and part of that is you can see in the margin, upper margin of the incision, that's an intramural fibroid. So if it's not very large, you can remove that, and that's about it. So there isn't anything special about intramural fibroids. If there is a large fibroid, can be removed, otherwise no. Well, it is more like the position of the fibroid, not its size. Of course, if it is a pea-sized fibroid, that's a different matter. That wouldn't really count in that. But if it's a say walnut-sized fibroid or it's more, sometimes you find that there is an orange-sized fibroid which has got a very small stalk and it's on the anterior wall. Obviously, you are tempted. You just apply a clamp, tie it, and remove that. That's simple. So it will depend upon where it is. You said removal of fibroid intrapartum. How do you do that? It was actually antepartum when I said. Intrapartum is at the time of cesarean section, not intrapartum during normal labor, not really that. So I didn't say intrapartum, it was antepartum. And antepartum means during pregnancy, and as was said in one of the slides, more likely in the first and the second trimester, not in later trimesters, until and unless the fibroid is subserosal and is causing more of symptoms, intractable pain. So antepartum, it is not intrapartum. Hemorrhage will occur with removal too. Internal myomectomy would be preferred. Of course, internal myomectomy would be there, but if the fibroid, if it is right there in front of you, the first fibroid that I removed during the cesarean section was, I was a registrar at that time. We didn't have so much of help. And when and obviously my experience was not really that great, but there was this fibroid. I came across this difficulty, but then I removed it and made the best of it. Patient survived and I also was all right. जी आप क्या कह रहे हो? तो इसको कुछ नहीं करना, आप cesarean section करोगे और बात. Another thing, for example, in this particular patient, the one that we discussed, our previous cesarean section was carried out because of fetal reasons. There was fetal distress and therefore cesarean section was carried out. And then she came in the postpartum period for postnatal checkup, etc. And I did not advise her myomectomy at that time. Because a woman who with a fibroid has become pregnant and has carried that pregnancy to term and was delivered of a live baby, in that I would not want to interfere with the reproductive possibility of the patient, and I would rather encourage her to complete her family before one resorts to myomectomy. So there have been instances in where patients presented with fibroid in pregnancy, the pregnancy was completed, the baby was delivered by the normally or cesarean section, but then I asked her not to have the fibroid removed but to go on to have another baby, and then to consider removal of the fibroid. What should we tell in exam? Small intramyometrial can be removed. Small intramyometrial fibroid. I mean, this is going into unnecessary detail. Keep it simple, this question, Dr. Hoda. Examination pattern. Now, examination pattern actually is, we are trying to formulate these cases into examination pattern. We haven't completed this exercise as yet, but we plan to do that. Now, that's going to be a little more exhaustive in the sense it will not involve so many slides, etc. It will not involve my talking about it, but what it will involve is that we go back to those questions of say that what would be your plan, then there will be a reasonable length instruction for the examiner also, that what is being asked and what the candidate is supposed to answer about that. So if you are asked about that, what would you do if a patient presents to you in first trimester of pregnancy with an intact pregnancy and a large fibroid, say at that time one can say 10 centimeters fibroid, which is in the fundal area. So how would you counsel that patient? Or then there is a patient who comes at 24 weeks of pregnancy and there is this fibroid and she complains of acute pain. What will be the management? And at that time, your answer has to go along with citing what the guidelines say. If in that particular subject there are guidelines, or if there are references which are available with you. So you can quote those references that because of this is that fibroid, this is the pain. I will admit the patient, I will explain to the patient about the pain and how it is to be addressed. I will carry out an ultrasound examination to see the size and type of fibroid, if that would be possible. And then also the morphology of the fibroid on ultrasound, what it looks like, and manage it conservatively. In case, let's say, the fibroid is interior, there are features of red degeneration, and it is subserous on ultrasound, then you can say that consideration to antepartum myomectomy can be given for removal of the fibroid. But the patient again will be counseled for the implications for that. Well, greater than 5 centimeters, well, that's an arbitrary thing. I didn't really come across anywhere, but I haven't read the RCOG guidelines about it, but you go through those RCOG guidelines. Are there any RCOG guidelines about fibroid pregnancy? 5 centimeter है तो उसके मुताबिक चलो, क्योंकि the question will be structured according to the available guidelines that are being practiced. Patient now in examination, actually patients will not be there. There will be role models. There will be either there will be role models or there will be mannequins. So a role model is there when you have to discuss with the patient, you have to talk with the patient, you have to counsel the patient. But if there are certain features which are to be assessed on, say, palpation, or which are to be demonstrated, then there would be an appropriate mannequin for that.
So can it show long cases?
And
Sir, you were saying long cases.
I don't know about that. I wouldn't know that. I don't know about the reversion to long. But if they come on there, but this is also interesting. As a matter of fact, when I heard about that they were doing away with long cases and this pattern was coming in, I was quite upset about it because I thought that long cases were important. But when I started looking at the structure of these short cases and those, then I thought that perhaps this is also a good method of evaluation in which you probably evaluate quite a few various aspects of the candidate. So that's it. Till next time. Khuda Hafiz.
Silent.
सर प्रेजेंटेशन आप ग्रुप में सेंड कर दें।